But this is what is my current passion more than anything else. Development of a model for treatment of borderline patients which can be used by non-specialists. It follows on the development of three major evidence-based treatments. I'll give you a brief look at each of those. These will be the ones which you will probably have heard about. Dialectical behavior therapy is by unquestionably the standard against which all others measure themselves. It's been around the longest. It was introduced in 1993 by Marsha Linehan, who described herself as a radical behaviorist, and it represented a radical difference from the prevailing psychoanalytic approach to these patients at the time, where the therapists are not passive and ask patients to take a lead. The therapists are coaches and their directive is accompanied by a group therapy, which up until then most borderline patients said, I won't do, I can't do. And those of us in the business say, oh, okay, write that one off. It probably would have been good for them had they done it, but honestly, it was just a condition of being in treatment then. And that was a very powerful addition. Anyway, it's been confirmed many times, and it's the most widely used nationally and internationally. Second model came along from two British psychoanalysts, Anthony Bateman and Peter Fonagy. Peter Fonagy is a developmental psychologist, a Hungarian of great charisma, who identified interactions between parents and children that he thought laid the groundwork for what later you see as the psychological handicaps of those people who develop borderline personality disorder. Anthony Bateman then implemented that, transformed that into a form of a treatment for adults, modeled on the idea that therapists, and again in this model, a group therapy, can help borderline patients learn to identify feelings and understand what's going on in themselves and other people and how they interact with each other, so that the relationships within the therapy become sort of like a laboratory for learning to mentalize, to think, be able to think about what's going on in the other person and how that's affecting you and vice versa. This has had several replications. McLean is proud to be one of only two institutions in the United States where this is practiced and taught. We have seminars here on a regular basis. Anthony Bateman and Peter Fonagy are visiting professors who come here regularly, and so many people on our staff have had personal training from them. The third is transfer and focus psychotherapy. This is a heir to the original psychoanalytic therapy developed by Otto Kernberg in 1968 when he first started writing about it. When managed care came along in the early 1990s, you couldn't get reimbursed for psychotherapies unless you could show empirically that it worked. So from then, for the next 10 years, he and some more research-minded colleagues kept refining transfer-focused psychotherapy until it became something that you could teach, and that you could measure whether people are adherent to it, and then did randomized controlled trial, which turned out to be effective. It is basically designed a twice a week individual psychotherapy whose defining features have to do with the old psychoanalytical model that patients are thought to bring to bear in their relationship to the therapist aspects of their past which cause them to distort what's going on, called transference, and that the clinicians then are there in a position to contain those feelings and those misattributions and to help patients correct them. That's had a few supportive replications itself. Now that was the first major generation. Those three, 1993, 1999, 2000, and I don't know, maybe about 2 or 3. So those are the 3 major models for treating borderline patients which have been empirically validated. Now mind you, there have been a lot of others, but those are the ones which have the most purchase, the most international recognition, and where there's an ongoing model for training clinicians. So, having established that borderline patients are treatable, I cannot emphasize enough that before Marsha Linehan developed her treatment in 1993, the literature and the folklore about the treatment of borderline personality disorder was that this was a chronic condition and untreatable. Worse than that, that these are patients who are going to cause their treaters to have heart attacks and lawsuits, and that there was that this is the patients who clinicians should avoid. Time magazine wrote an article, cover page, the disorder clinician, doctors, not just psychiatrists, doctors least like to treat. So that this really was a transformation of that thinking, that now there were treatments which could effectively help borderline patients, and it was a major counteraction to all the negative stigma and misinformation about the treatability of this disorder. So once this was established, of course, then you want to do other trials to replicate. You want to see whether this works in other people's hands at different sites. And yet you can't do it anymore with treatment as usual. That's what the first trials were all measured against. Treatment as usual is that you just take what the similar patients and they get whatever would ordinarily occur for them starting in that outpatient clinic or that hospital. And so that was what the success was measured against. But you can't do that a second time around, because once you have established effective treatments, it's unethical to the government. Nobody could ethically authorize giving people something that is known not to be effective. If you're going to do research, then you have to have an alternative treatment which at least has a knowledgeable clinicians with a reasonable model and where they have been trained to adhere to. So that's where this slide comes in. Transference-focused psychotherapy was found to be equal to supportive therapy. Transference-focused psychotherapy was twice a week. Supportive therapy was once a week. This is a different model that I didn't mention, but cognitive analytic therapy, something that was used in Australia, was found to be equal to case management therapy. Far less training for the therapist and less intensive. Mentalization-based treatment was found to be equal to structured clinical management. Far less intensive training, far less intensive therapy. Now, Bateman and Fonagy would say, well, it isn't really equal, that the decline was faster in the people who got MBT. But the overriding finding was that another treatment could do nearly as well. Then this last one, DBT equals good psychiatric management. DBT, as you know, is the group therapy and the individual therapy. Good psychiatric management, which is what I'm going to talk about now, is once a week. This is the trial. Published 2009. First time I heard about it, though I had been a consultant on what was called general psychiatric management. After this study was published, we renamed it Good Psychiatric Management because we didn't expect, nor did the people who did the study, we thought it would be fine, but we did not expect it to be as good as dialectical behavior therapy. I first heard about these results before it was published from Marsha Linehan, who emailed me to offer her congratulations. Oh, what were you talking about? Well, this therapy you developed did as well as dialectical behavior therapy. What therapy is that? Well, I never thought of myself as having a brand name therapy. I was this generalist, I'm just a guy who's been in the trenches far longer than anybody else and always write the books about what, everybody should do and not the books for specialists. Though, that was surprising, and what was much more rewarding for me was that she said, and you should know that this was good quality DBT. Usually when your baby runs in a race against somebody else's, if it doesn't do better, it's because it wasn't done right. So, good psychiatric management equal DBT and decreasing deliberate self-harm, hospitalizations, depression. It was a little bit better for borderline personality disorder with those patients with more comorbidity. The therapists were not beginners. They were people who had an average of 5 years experience working with borderline patients, and they wanted to participate in this project. So they're not people off the street who had no interest. And then the guide was this book that I'd written. Paul Links, who was one of the investigators, McMahon and Links, used a book that the two of us had written as basically the manual that guided the interventions. So all of a sudden, I'm thinking, well, there's something for me to do here. This is a new page in my life. And so I've gone on a mission, because my mission is to get clinicians who otherwise have not been trained or who have a lot of misinformation about what they can do to help people with borderline personality disorder to approach this with more enthusiasm and to improve the quality of the training that clinicians of all stripes get. Let me tell you more about what good psychiatric management looks like. So this is meant to be a treatment which borderline patients should receive when they first go for treatment, and that all professionals should know. And then those who don't do well with it, then you go on to the specialty treatments, which require clinicians with more training and where the treatments are more intensive. So what's it start with? It starts with diagnostic disclosure. Sounds simple enough, but we're working upstream in strange ways with this diagnosis because it has never had a biological treatment, a medication treatment. Psychiatry has never much embraced it, and most psychiatrists, and indeed many other mental health professionals, still see this as a pejorative diagnosis that they don't want to give to people because, what are you going to do? Tell somebody they've got a untreatable and intractable disorder? Or, alternately, tell them that they've got a disorder that I don't know how to treat because I haven't had any training. In good psychiatric management, you start out with an unapologetic disclosure of the diagnosis. Perry Hoffman, who's the head of NEA BPD, a national organization for diminishing the misinformation, increasing awareness about borderline personality disorder, and whose organization is responsible for these videotapes, which now become a archive that are available to people, told me when she heard I was doing this talk tonight, make sure you tell people that we have a book coming out. So the book has to do with stories of recovery. I think there's 21 reports by people who have been in treatment for borderline personality disorder, some of them from here, but a lot of them from other programs elsewhere. And one of the themes that is recurrent in those reports is that people had received a lot of treatment ostensibly for other disorders, and what a huge difference it made when the borderline diagnosis was given and their families and their treaters were on the same page and could understand that this was not something that was going to go away soon. It was not going to go away due to drugs, but that it could go away, and if you get it to go away, it goes away permanently. So that it is a very powerful but very different message than most of these patients who wrote these reports. Their past experience had been very different than that. Diagnostic disclosure is very open and unapologetic, and that's how you start. This way it's very medicalized, you know. It is not in like the traditional psychotherapies where you decry diagnosis, everybody's unique, and that you don't want to compartmentalize people, and you want to hear everybody's story for what's unique about it. This, for better or for worse, because there's a lot of truth in that message, the other message, says you got a disorder. A lot of other people have similar disorders, and there's a whole body of knowledge about this disorder that we can bring to bear. Psychoeducation, that's the second part, is very heavy on psychoeducation. Those of you who have had clinical exposure to me know that it's very common for me to interrupt whatever we're talking about to do asides about the, you know, this is something which is often, you know, the back in 1975, you know, it used to be thought that this medication worked, but then it was discovered that da-da-da, and, you know, so being psychoeducational, in particular about the course, what is the expected course. I don't know what my next slide is. I'll take a look. Yeah, here we go. And the genetics. So every patient, every family, every patient's family, every clinician should know this. This is not a disorder that comes simply because there's bad parenting or trauma. That can happen, but there's a substantial heritable component to this. Parents of people whose kids grew up to be borderline will say that they could identify differences in those children early on. I was talking with somebody today who said, you know, that you're more hypersensitive, and that hypersensitivity then oftentimes generates its own problem, because parents who might be fine for another child but who themselves are sensitive then get very reactive, and then the child gets wound up, and so you get something that perpetuates itself. There's no blaming in that system, but it is very important that everybody start with knowledge that there's a very significant heritability disorder. We don't know exactly what that is. There's two major candidates. One emphasizes the interpersonal hypersensitivity. That would be that the kid looks at the caretaker with very suspicious, wary eyes and is likely to be hard to soothe. The other one is that the kid has a dysregulation in their emotional system, and so that when they get scolded, they have a much stronger reaction than somebody else. I like the first one because it takes it back into not just the scolding, but the meaning attached to it by the kid. Interesting part of this. Now, there have been 3 twin studies which have confirmed all this, which is remarkable. The first one was in 2001. Till then, almost all the literature about this disorder emphasized that this is a disorder caused by a bad environment. There's a lot of parent blaming in it. Now, parents who are here, you're not exempt, but you have to look at a much more complicated model. That is, this was not an easy kid. And the literature shows that the components which seem so different. I was a principal investigator on one of these studies. We started out with the question as to, you've got emotional problems, you've got interpersonal problems, you've got behavioral impulsive problems, and then you've got these cognitive problems with brief paranoid ideas, dissociation, body image and self-image distortions. Those are 4 different components usually of of illness. So does borderline personality occur because 2 or more of those co-occur just on a statistical basis because they're widespread in the general population? That was a model which was sort of a more statistical probability one. The other was that there may be something internal that coheres these things and causes them to happen in the same person. To my surprise, and actually it was very rewarding, but I was really open to both possibilities. There is a latent core factor. So that really talks about the validity of the diagnosis, that there is some integrity to it. It isn't just the collection of the symptoms, but they have a unifying force. This is the slide that talks about the course. People get better. The red one is the number of criteria people have and how that decreases over time. The green one is the percentage of people who remit, meaning that they go below 2 criteria and stay there for more than 12 months over time. It's actually a little better than that by 10 years. It's more closer to 85%, I believe. But in any event, the chart is very dramatic. And how in the world could those people who wrote textbooks about this disorder have so misrepresented it for so many years? Gulp. I'm going to only say is that the studies that we had were on treatments all showed no response. With psychoanalytic therapies and pharmacotherapies before DBT, and that the patients who lived most vividly in everybody's mind and became the prototype for, you have borderline personality disorder, that's the person who keeps coming back to the emergency room, so-called frequent flyers, or the people who keep coming back into the hospitals over and over again. That became, in the minds of the mental health profession, that's what borderline personality is. That's what these people, that's who these people are. We never saw that the ones who got better and didn't come back. So it got blown way out of proportion, the people who didn't get better. And of course, those that were in prolonged treatments where the treatment was probably making them worse. So it combined to give a very bad reputation to this disorder, which these, so first was empirically validated treatments, and now longitudinal studies, a major counteraction to the negative ideas about this disorder. These started in the 1990s and continue to the present. Mary Zanarini, my colleague here, is now in the 20th year of her follow-up of patients who were treated, who started their course here at McLean Hospital. The other major study was one that I was involved with, the collaborative study that was very representative of the general population of patients, so that was not selected on the basis of the way McLean patients are. They were from like 19 different clinical sites in Boston, Providence, New Haven, and New York. And so they were very representative of the general population. Very similar results. So back to GPM. Oh, and this is the bad news from the longitudinal studies. Borderline patients get better symptomatically. That was big news, surprising news, shocking news even. But most of them do not get better in terms of having a quality of life. The GAF is the functional life. Do you have good partnerships and good work? It's a fairly straight line. By 10 years, only about 20% of people with borderline personality disorder had stable employment and stable partnerships. In Mary's follow-up, it gets higher than that as time goes on. But nonetheless, that's a very sobering counterpoint to this diminution of symptoms. We'll come back to that. So you start GPM this way. You don't say, I'm going to stick with you through thick and through thin. You can count on me. You say, I'll stick with you if I'm being helpful. And we'll know whether I'm being helpful to you by taking a look at whether you're changing. So you don't stay in treatments, and you don't want patients to stay in treatments where they're not getting better. Now, you could never have said this before that slide back here. These were not patients who were given specialized treatments, especially this collaborative longitudinal study. None of them. This is the normal course of people who come for treatment across the demographics, except, of course, they're all in the Northeast. But so you, if you're a patient, should be told that you should expect to get better over time. And it's not like everybody's going to get better by 2 years, but on this it's 34%. And by 4 years, it's nearly 50%. That doesn't mean you wait for 2 years or 4 years either. What it means is that borderline patients should get better, most of them. And if they're not on an upward trajectory in their course of treatment, you raise questions. Is there something wrong with this treatment? You don't say, oh, the patient's getting worse, that means we should do more of the same. You say that maybe something in this treatment is actually interfering with the natural course of the disorder, because people who don't get any of this expensive or intensive treatment generally do okay. They get better. They get better. This is important. In 1996, I wrote an article in which I presented a case of mine. I had Anthony Bateman as a discussant, and I had Otto Kernberg, who's the developer of transfer-focused psychotherapy, as the other discussant. And so we interrupted the case, and they were asked to respond to it at different points as to what they would do through their different models. There was lots of interesting disagreements. And, but one of the things I said to the patient is I told her that I thought she should forego getting into a romantic relationship, and that she should focus her attention, her skills, and her energy on getting some kind of successful work life. Neither of them liked that suggestion at all. And it really was very much the sort of thing that hadn't and still isn't done very much. Psychiatrists, most people in medicine, do not pay much attention to the person's life, functional life. They pay attention to decreasing symptoms. And so with time, I mean, we introduced this in our outpatient clinic, and the Gunderson residence opened, and we introduced it in the Gunderson residence, and the time framework keeps getting cut back. First time it was like, certainly by a year, everybody should be either in work or school. Then it was 6 months. Everybody should be in work or school. Then it was 3 months. Everybody should be in work or school. Now it's like 6 weeks in work or school. And it's like when Marshall Linehan introduced the fact, you know, DBT, being in a group therapy was not an option. If you'd asked the patients, I don't do that. I can't do that. But when it's not an option to not do it, most people do it, and it changes everything. So we do not have research to confirm this. But I can tell you that just by observation and follow-ups, when you talk with people who've left our program, you know, most of them are out in the world. They're not any more or any less symptom-free than those people who do not have this message, but they are, for the most part, into life in a way that is much more rewarding for them, and which I think, when we do the follow-ups, will show that a real radical change in those statistics that we found on the follow-up studies, where people got all the symptom remissions, but they didn't have good lives. I think it's going to be significant. My estimate is that something like 65%, something like that, of the people in our outpatient clinic and our Gunderson residents are working and or in school. I don't know if I'd say a year or two, but certainly by 2 years. And it's not because we're vocational counselors, but we do emphasize it. And I think it's a radical new thing. Anyway, that's part of good psychiatric management. Parenthetically, the other models of treatment, without any empirical evidence, research to justify it, are now doing the same thing. So TFP and MBT, and I don't know what the DBT is, but to get a life worth living, you need to find ways to maintain self-esteem and social supports that do not depend on exclusive partnerships or your parents. Vocational activities offer the best ways to achieve these goals. That's good, basic GPM message. Fourth principle is support. Nothing new about this, but it certainly contrasts, and it's only worth mentioning, I think, because it contrasts with some of the earlier psychoanalytic traditions where the therapists were so passive. Here, it's not just listening, you're active in expressing concern and giving advice, psychoeducation as ours, and availability. Now, this is probably, I think if anybody wants to hear about that, we'll go into it. Otherwise, it's a little technical. enroll a patient and take care of themselves. You don't offer to be somebody who can know what they're thinking without being told, or know what to do without their input. What you do between sessions in the GPM model, in fact, I think this is true just in general, whether people get better or not depends less on what goes on in their therapy sessions than on whether, when the therapy session is over, they think about it and they work on it. So it always troubles me when I say somebody and I say, did you think about what we talked about last time? And they said, I don't remember. Well, I remember. Something's wrong with this picture. We're encouraging people to become involved in their own rescue. And finally, it's flexibly multimodal. That means that good psychiatric management wants to include groups, family, medications. There's no prescriptions that you can't do this and you should do that, but you try to make it available according to what the patient needs and what the resources available are. Now, in closing, borderline patients have a right to expect that professionals who treat them have been trained to do so. It is sadly still often not the case, and hence so many people with this disorder write reports like those I talked about in this new book, and you hear about it all the time. I was treated for 8 years for depression or bipolar disorder or ADHD, or sometimes even the clinicians knew the person had borderline personality disorder, they just didn't know what to do with that. This good psychiatric management offers an opportunity, a model of treatment which can and should be incorporated into training programs. In 2013, Lois Choi Kane and myself started what we sort of optimistically called a Borderline Personality Disorder Training Institute. And with support from benefactors, we have undertaken a number of initiatives. Some of them are self-supporting now. The MBT training, mentalization-based treatment, which we started out by getting our own staff trained. We now have a clinic in the outpatient clinic led by Dr. Brandon Unruh, where we do training for other clinicians. And Bateman and Fonegay remain involved with that. We do good psychiatric management workshops. I do that, but the model for that is that I usually like to take somebody else with me so that there's a good number of people on our staff that can teach it alongside me. Once people at the sites that we go to, it's usually a day, sometimes half-day workshops where we go and teach people, just do the basic training, what you do with good psychiatric management. We try to get somebody from that site to then come to what we call the training trainers workshop. And then they come to these training trainers workshops where they learn to train other people. And we did 2 here, McLean-based, in the last couple of years. Wonderful attendance and wonderful, we've got a newsletter started on the problems of implementing this into training programs. But that's, we have one coming this spring at Northwestern in Chicago, and one in Baltimore next October, and one in Los Angeles the following year. So those bring people who have responsibility for training junior faculty, sometimes senior faculty, who are responsible for training others about treatment of borderline personality disorder come to this, and then they go back qualified to be training other people. Lois Troy Kane is doing several initiatives, one in the Dominican Republic, which is where she is this week, another which is going to be in several sites here in the United States, where she's trying to teach local clinicians up to competence in good psychiatric management, services for underserved populations. Recently started a webinar, McLean has. The next one is by Michael Hollander, and you're all welcome to take that information down. I don't really know whether they're every week or every month. They're every what? Once a month, yeah. So you take that down, and then you can look and you can see the past ones that have already been done. I did one. Lois has done one. I think Maureen Smith has done one. Blaze Aguirre from our adolescent program has done one. Michael Hollander is doing this next one. We have family guidelines and workshops, including this monthly workshop. And we have these pamphlets about so that clinicians take them home and take them to their offices and distribute them. So I will close with that statement about what we're doing in terms of trying to upgrade and expand the services for people with borderline personality disorder. Thank you.
Thank you.
So, I got done with enough time that you can now ask questions about what you really wanted to know. So, the question has to do with, there's a disorder called complex PTSD. Is that part of borderline personality disorder or separate? Complex PTSD is a disorder which is a form of post-traumatic stress disorder where the stresses originated in childhood. And when it became clear that 70% of people with borderline personality disorder reported having childhood abuse experiences, it was wondered whether really that explained how they got borderline personality disorder, and that borderline personality disorder should be reconceptualized as an atypical form of post-traumatic stress disorder. The difference is that the people with complex PTSD grow up sufficiently damaged by that trauma that they remain extremely distrustful and cannot undertake the kind of challenging and the need to take responsibility for your life that the people with borderline personality disorder will profit from. And they're often very vigilant, they often have dissociation, and they may look borderline because they are so in need of help, but they are much more distrusting, they have the flashbacks and that sort of thing. Now, the 70% of borderline patients who have histories of childhood trauma that's not a lot higher than people with other disorders. And you don't want to minimize the significance of it, but as a larger look at the causes for borderline personality disorder, it accounts for about 15% of the variance. Just like genes count for 55%, childhood trauma counts for about 15%. That doesn't mean it's 15% for everybody. For somebody, it's going to be 25%, a standard deviation either direction. Some people, it's going to be none, you know. And so it varies. The more what we know now is that whether children who have abusive or traumatic, whether they have abusive experience for sure, whether it's traumatic or not depends on two things more than the trauma, the events themselves. How resilient the child is, kind of ability to manage stresses, and that has a lot to do with their genetic disposition, and whether in the aftermath of that trauma they have a family that they can, or teachers or counselors, or that they talk it through. Now, when you talk to people who develop borderline personality disorder, they're oftentimes kids who are going to be particularly responsive to stress and have a harder time, less resilience than kids who don't have a genetic disposition for this disorder. And they frequently have very alienated, or at least very complicated, difficult relationships with their caretakers. So on both sides, one would think that they're going to be more disposed than other kids to show longer-term consequences from childhood trauma. For the most part, not for the most part, I should say, I think one of the frontiers, we wrote off the possibility, this institution included, for a long time, the people who had a lot of trauma in their background, they needed to be treated with support, and you wouldn't ask them to relive the experience because it would just, they would just get unwound and get worse. We now have a more nuanced approach to that. Some people will and some people won't. And that because it can be so healing to relive such experiences within a supportive context, there's now much more experimentation and exploration of asking people to relive those memories than there used to be.
What
Yes.
if they're so young they have no memory?
If they have too young to have memories, they're not going to be able to do much with it. Well, this big trauma and little trauma, it's less an issue of big trauma and little trauma. It has more to do with how sustained the trauma is, and in some ways what type it is. You often think of the worst trauma as sexual or violent, but the ones which are more apt to be more damaging are those more sustained things like neglect and emotional abuse. Schizophrenia, I'm just using that as an example of something that is far more heritable than borderline personality disorder. I was using major depressive disorder as a disorder which is because you read so much about this brain disorder, that is got a chemical imbalance and all that. It's got so biologicalized depression, but it's actually less heritable than borderline personality disorder. I was just trying to make that point. There may be some genetic relationship to borderline personality disorder, but it's very complicated and not well understood. Yes. No, it isn't great. And what I said was that, when in our follow-up studies, you only had about 35% by 8-10 years who had stable partnerships or stable work, and but as time goes on, it got better. But I now believe that with the psychotherapies actually giving a lot more attention to that, and certainly an institution like ours, which says, get a job, and people do, despite the protests, I can't, I won't, I believe it's going to be much better in the future. Already there's a change. It's just too bad. I'm sort of cut back on my administrative responsibilities as of January 1st, so one of the things I want to fill that time with is I want to do the follow-up study on the people in our outpatient and our residential program from that point of view only, because the public health significance of that is enormous if it's as good as I think it is. Psychiatric disorders cost far more money on the basis of social disability than they do for treatment. And we lose sight of that. If you've got a treatment where people can go back to work or stay out of jail and stay out of emergency rooms, you know, you've got it's enormous public health significance to that. It's a good question, and you can speculate about it. That one model would be that the people have gotten so beaten down by their illness that they don't have hope, or they and their families and everybody else is content to not expect more from them. That's quite possible. It is true, though, that people who have the symptom remissions, that is a predictive of better function than people who don't have the remissions. I had hoped it would be the other way around, too. But we didn't have quite enough statistical power to show that, but that if you have good functioning, then that will predict symptom remission. The problem is that unless you got some significant reduction in symptoms, you're unlikely to get a job or stay in school. So, but nonetheless, I think it actually moves that way, that they feed off of each other. Yes, yes. Let me repeat that for everybody. Yeah. Here the suggestion is that people can keep their symptoms remitted because they avoid the situations which are stressful. And it's true, at least in earlier follow-along studies, is that there was a correlation between more avoidance in people as their symptoms remit. Well, universally, there are far more people with borderline personality disorder seeking services than there are qualified treaters. The diagnosis has been pretty comfortably adopted through much of Europe, certainly Canada, and to some extent South America. The quality of services in those countries which have more standardized care are likely to be more standardized. Not as good as here and not as bad as here. And that you can just think for yourself. Like I was in Norway in December. You know, generally speaking, I would say most borderline patients will have a better turn there than they will here, because it's a highly socialized country and medical services are more socialized. On the other hand, I mean, there is no place like McLean. We have 3 dedicated services to borderline patients. That is virtually unheard of elsewhere, even in this country. And we hope to have a 4th.
What would be the 4th?
For males. What happened is that 3/4, even more, 80% of the people in clinical settings who were with borderline personality disorder were female. So again, people like me said, well, gee, it's predominantly for females, and that's because it's a relational disorder, and females are more relational, and men are more instrumental, and all this stuff. And then they did the community-based epidemiology, and damn if there weren't just as many males as there were females. And I said, well, that can't be true. It's bad methodology. So then another paper came out, same thing. No, the males are there. They are more apt to go to forensic settings because of hitting somebody in the mouth, or into substance abuse settings. But when Brandon Marshall went public about having borderline personality disorder, it was a major step towards making this disorder something that males could identify with. And we have never had a female poster child. In any event, that was followed in this setting at least, and I think I've heard elsewhere too. More males are now seeking services for borderline personality disorder. Oh, absolutely. I mean, borderline personality disorder represents 2% of the population, which is as much as there is schizophrenia and bipolar disorder together. It receives less than 1%, and maybe far, far less than that, but, of the federal expenditures on research. It is scandalous, and it has to do with the turn towards biological psychiatry. Borderline personality disorder does not have a medication. A turn away from doing psychotherapy research of all kinds. And the stigma, which has permeated attitudes about this, that it is a disorder that people neglect. And when you get an ideologically fixed director of the National Institute of Mental Health, like we have had for the past 10 to 15 years, we used to have a big advocate there, and we had a growing body of research, but when the funds got lower, and he decided that he wanted to have to determine what should be prioritized in research, it's more or less dried up. He's gone now. I don't expect there to be a radical change. He went to Google, where Google is going to invest in, has a budget that is larger than the National Institute of Mental Health. Just boggles my mind. Whether that, I mean, that's not going to do much good for us. You ask what you can do is, NAMI is the advocacy, the best, the NEA BPD, which is that part of our national, that's the only, well, there are two major national organizations that are developed around helping people with borderline personality disorder. The NEA BPD, I wish I had their website number up there.
It's neabpd.org.
neabpd.org. And TARA, T-A-R-A. If you get that far, the rest I think will spin itself out. But NEA BPD would be the one that we're most affiliated with, and they're not primarily an advocacy organization. They're more information and awareness. But nonetheless, that's an organization that you should contact to see whether there are things that you can do. Of course, there's there's lots of other things that can be done. So, no,
Right?
no, you don't, and that's where we want to get a foothold first with psychiatry, and get them in positions where they can teach others.
Right.
And but yes, primary care physicians is another major audience where good psychiatric management can be and should be taught. Family services organizations. is very busy overseeing this initiative. I don't travel lightly and I don't travel happily, but I've done more, Linda's here. I've done more traveling in the last 3 years than I probably did in the last 10 to 15 years before that. I just do a lot of traveling now because I've got this bee in my bonnet. It is pretty high. And I've read it, but I don't know what it is. Some of the more identifiable or known statistics are that it's between 15 and 20% of all psychiatric admissions. 15-20%. 15 to 20% of outpatient clinic visits. 9% of emergency room visits. 6% of primary care physician visits are by people with borderline personality disorder. It is an enormously important public health issue.
So
And I think on that note, I'm going to go home and have dinner. Thank you very much.